This is the last lecture in the cell injury, and it will be followed by the acute inflammation and healing in the next week. In this lecture, we will discuss, in the last lecture of the cell injury, we will discuss the intracellular accumulation, steatosis, the protein accumulation in the, what are the clinical setting of accumulation of the intracellular pigments, in case of the endogenous or exogenous substances. All these would be discussed here in this lecture, and at the end we will discuss the aging and the progressive senescence that is associated or accompanied with the aging, and the role of telomere and telomerase in aging, and also in the cancer. Intracellular accumulation. There are certain substances that accumulate under some circumstances and in certain or specific clinical situation. Those substances might be harmless. They don't do anything. They don't incite any reaction in the body nor injury. Or sometimes those substances may locate within organelles such as lysosome, cytoplasm, or the nucleus. Or some of those substances may be endogenous, synthesized by the affected cells, or might be exogenous from the outside. The general pathway by which cells can accumulate abnormal intracellular material are illustrated in: first, abnormal metabolism, as in the fatty liver, in the fatty changes in the liver. When there is abnormal metabolism of the lipid, it will lead to the accumulation of triglyceride in the liver, causing fat changes. In protein mutation, when there is protein folding transport, there is defect in this pathway, and it will lead to the defective protein accumulation in the cytoplasm, such as in the alpha-1 antitrypsin deficiency. When there is alpha-1 antitrypsin deficiency, it will lead to the accumulation of the alpha-1 antitrypsin globules inside the parenchymal cell like the liver. Lack of enzyme responsible for breaking down of certain compounds, such as in glycogen storage disease, lysosomal storage disease, because the cycles of these compounds in the body need certain enzymes. Sometimes there is deficiency of the substrate, deficiency of those enzymes lead to accumulation of those substances or substrate in the organelle. One of them is the lysosomal storage disease. Ingestion of indigestible material, such as patient working in factories, rubber factories, plastic factories, lead factories, lead to the accumulation of the carbon or silica or the miners that the patient or the people that are working in the coal miners, يعني بمناجم الفحم, it will lead to the inhalation or ingestion of the carbon particles, and these carbon particles, it will engulf by the macrophage, and then it will accumulate in the tissue in the body like the lung. Now we are coming to the first topic in this intracellular accumulation, which is fatty changes. Now, normally, free fatty acid from adipose tissue or ingested food transported into the hepatocyte to be metabolized. Because they are esterified to triglyceride, converted to the cholesterol or phospholipid, or oxidized to ketone bodies. The transport of the triglyceride from the hepatocyte require complexing with apoprotein to form lipoprotein حتى in order to transport ينتقل which then traverse the circulation لأن هو triglyceride لحاله ما يقدر يعني transport by itself, should be complexing with apoprotein. لهذا تتذكرون when patient during starvation, when there is deficiency in the protein, it will lead to the fatty changes of the liver. ليش? Because the triglyceride will accumulate in the liver because there is no protein complex with the triglyceride to be transformed or transport into the circulation. فيتجمع فيصير البيشنت. سألوني أكثر من أحد إنه ليش يصير عندنا fatty changes من شخص بالجوع الشديد أو بالنقص في البروتين؟ لأن we need the apoprotein to be complex with the fat اللي هو triglyceride in order to be transport into the circulation. Excess accumulation of triglyceride may result from defect any step of the fatty acid entry to the lipoprotein exit. There is cycle, lipid cycle أو fatty acid cycle بالbody included بالliver. It's طبعا I don't want to engage into the biochemistry of the fat or the free fatty acid, but we have to get to the most important point from this topic. When we have any step when there is any defect in any step from fatty acid entry to the lipoprotein exit, it will lead to the accumulation of the triglyceride in the liver. So, what is the steatosis? Abnormal accumulation of triglyceride within parenchymal cell. It is not cholesterol, it is not free fatty acid, it is not apolipoprotein. Steatosis is accumulation of triglyceride. We have to be specific in certain terms when we use it. Mostly steatosis seen in the liver, which is the major organ involved in the fat metabolism. When is the fat metabolism? In the liver. So the steatosis or the fatty changes is mainly seen in the liver, but it's also seen in heart, skeletal muscle, kidney, and other organs. This is an illustration, and this is a picture showing the fatty liver. Look at here the mechanism which lead to accumulation of the triglyceride in the liver. This is a free fatty acid and the fatty acid triglyceride. These are the steps which is required for the fat metabolism. Triglyceride here with the apolipoprotein, lipoprotein, lipid. When there is defect in any step of this, it will lead to accumulation of triglyceride in the liver, which appear as fat globules occupying the hepatocytes, pushing the nucleus into the side. تشبه السيجنترين قصير. And this هذه fat globule عبارة عن مثل يعني clear space, but when we stain this liver by the oil red O or the sodium black to stain the fat, it will appear that these fat globules are filled with fat. The type of the fat in the liver in the steatosis is triglyceride. What are the main cause or the most common cause of the fatty changes in the liver? Alcohol abuse, especially in industrialized nations. يعني بالدول المتقدمة, because they consume large amount of alcohol, so the alcoholic patient may get fatty changes in the liver. Is there any other causes of fatty changes? Yes, as we said, protein malnutrition, obesity, sumna, diabetes mellitus, anemia, anoxia, and toxins are the drug are also considered one of the causes that might lead, some of the drugs that might lead to the fatty changes in the liver. Carbon tetrachloride and protein malnutrition decrease the synthesis of the apoprotein. Anoxia inhibit fatty acid oxidation. Starvation increase fatty acid mobilization from the peripheral stores. Effect of the fatty chain depend on the cause and severity of the accumulation. When mild, the effect on cellular function is so little, sometimes we ignore it, but sometimes when there is severe fatty changes, may impair cellular function, especially of the liver. Sometimes in carbon tetrachloride poisoning, the damage, it would be really vital intracellular process that irreversibly impaired. In this case, the changes is irreversible because it will lead to the necrosis of the hepatocyte. Otherwise, the fatty changes in other situations when there is mild, not affected dramatically the vital process of the liver, so it would be reversible. Grossly in the liver, when there is mild fatty changes, it might not affect the gross appearance of the liver. But while there is more accumulation of the fat in the liver size and the weight of the liver size become more enlarged and with yellow appearance. The weight of the liver reach 3 to 6 kilogram, while the normal weight of it is 1.5 kilogram, and it appear as bright yellow, soft, greasy in color. Microscopically, early fatty changes is seen as small fatty vacuoles around the nucleus, microvesicular vacuoles in the cytoplasm around the nucleus. Later on, those vacuoles coalesce, unite, fuse together to create large, clear vacuole space that displace and pushing the nucleus into the periphery. This is what we have seen in the liver. In the heart, prolonged moderate hypoxia, as in the cases of anemia, فقر الدم, it results in focal accumulation of the fat, given appearance or the characteristic of tiger-like or tubby cat pattern, مرقطة. However, in more severe hypoxia or in cases of diphtheria, such as toxic myocarditis, it would result in diffuse fatty changes. This is a fatty changes in the liver. Patient with alcoholic. Look at, because of the accumulation of large quantity of the neutral fat within the liver cell, it will give rise to the uniform yellow appearance, greasy, soft to the liver. This is the fatty changes in the heart. The muscle of the heart showing mottling, patchy, yellow streaks, تشبه يعني تكون مثل المخططة أو mottling منقطة، تشبه tiger like or chubby cat كأنه المرقط, because of the patchy accumulation of the fat in the heart of the patient with anemia. Cholesterol and cholesterol ester. Normally, cellular cholesterol metabolism is tightly regulated to ensure normal cell membrane synthesis without significant intracellular accumulation. The phagocytic macrophage, when become in contact with lipid debris of the necrotic cell, may become stuffed with lipid, give appearance of the foam cell. So what are these foam cell? Foam cell are the macrophages that stuffed with the lipid. شنو هو الليبيد؟ هو الكوليسترول موجودة بالماكروفاجز، تختلف عن fatty changes. In atherosclerosis, smooth muscle cell macrophage are filled with lipid vacuoles, which is composed of cholesterol and cholesterol esters, which give atherosclerotic plaque their characteristic yellow color. فبتصلب الشرايين، من تصلب الشرايين lead to accumulation of the fat in the wall of the blood vessel. فمن accumulation of the fat اللي هو cholesterol and cholesterol esters وين تكون بسموث muscle وبالماكروفاجز، تترسب على ال wall of the blood vessels, causing damage to the endothelium of the blood vessels. This damage to the endothelium of the blood vessels, it will lead to the when the platelet or the blood component, ما أريد أشرح in details بهاي, we are coming to it in the hemodynamics. When these coming, the blood component, as example the platelet, in contact with damaged endothelial cells, it will cause accumulation of these substances, which might cause thrombus, which might lead to the occluding of the blood vessels, subsequently cause ischemia because of narrowing of the blood vessels, lumen of the blood vessels, decrease in the blood supply to the tissue and organs, and if there is complete occlusion of the blood vessels, it might lead to the infarction, تجلط، جلطة. لهذا تصلب الشرايين يعتبر من الأمراض الخطيرة اللي should be treated in order to avoid any subsequent ischemia or infarction of the tissue. Sometimes there is hereditary and acquired hyperlipidemic syndrome. What does that mean? Sometimes there is gene that run in the families that lead to the hyperlipidemia in young age group, because the macrophage accumulate with the macrophage stuffed with the lipid accumulate in the skin or tendon, or which form masses called Xanthomas. This is atherosclerotic in the aorta. This is ulcerated plaque, because when the plaque abundant fat within the large atheromatous plaque confirmed by yellow color of the lesion, plaque on the right has ulceration. هذا الulceration, or there is because of the accumulation of this fat in the wall of the blood vessels, or in the causing damage to the endothelium, so ulceration. هذا الulceration ممكن يجي له بعدين when touch with the get into contact with the blood, بشي يصير عندنا slowing of the blood supply in this. تخيلوا tube، هو البلد vessel عبارة عن tube، لما يكون اكو بيه خرابيش on the side of the tube, the blood will not run smoothly in this tube. So in such a case, it will lead to the accumulation of certain blood component RBC and platelet when تكون تترسب بهذا المكان. فمن تترسب بهذا المكان ممكن later on cause thrombus, and ممكن thrombus يكبر ويكبر ويا البلاك ويكبر ويمكن occluded the blood vessels, and subsequently might lead to the obstruction or occlusion of blood vessels, and then to the necrosis. And this is xanthoma accumulation. نشوفها عادة هذولا بالهايبرليبيديميا اللي هم hereditary hyperlipidemia, subcutaneous lesions. This is a characteristic of the patient with hereditary hyperlipidemia, accumulation of the cholesterol-filled هاي كلها هاي بدنا نشوفها بالمايكروسكوبيكال examination. we will see that macrophage filled with the lipid اللي هو الكوليسترول يسموها foam cell in the skin and subcutaneous tissue. This is another picture of the xanthoma of the hand showing this nodular lesion in the skin and subcutaneous tissue of the hand of the patient with hypercholesteremia. It's mainly consisting of foam cell, macrophage stuffed with cholesterol. In this picture, showing skin biopsy in xanthoma, which appear as foamy lipid-laden macrophage. All of these macrophages are loaded or stuffed with the lipid, which is filled with the cholesterol. These are, look at them, these are foam cell, which appear as clear cells stuffed with cholesterol, interspersed in between the muscle fibers and in the skin and subcutaneous tissue of the patient with xanthoma. Protein. Now we are coming to another substances that might accumulate in the cells and tissue. In disorder with the heavy protein leakage across the glomeruli, filter proteinuria. When there is proteinuria, that means that the glomeruli passing protein in the urine, as in the cases of the nephrotic syndrome, when there are certain conditions, renal condition, in which there is increased pinocytic reabsorption of the protein, result in the appearance of the pink hyaline cytoplasmic droplet in the renal tubular epithelium. In this syndrome, the patient has a proteinuria, has generalized edema, has or periorbital edema, sometimes have hyperlipidemia and hypoalbuminemia. These group of disorders affect the glomeruli. Most of the minimal changes glomerulonephritis, which is mostly occurs in the children, and in the membranous glomerulonephritis and other types of the glomerulonephritis in which cause nephrotic syndrome. In those cases, the patient presented with puffiness of the face, edema, periorbital edema, and when we examine the urine showing protein urea. In addition to the there is we see that pink hyaline cytoplasmic droplet in the hyaline in the renal tubules. The process is reversible because if the treatment, if the patient is treated, the proteinuria and the protein droplet disappear. Sometimes there is accumulation of synthesized immunoglobulin and rough endoplasmic reticulum in certain disease such as multiple myeloma. There is accumulation of immunoglobulin in rough endoplasmic reticulum of the plasma cell, resulting in aerosol bodies, which is seen in the plasma cell disorders or in neoplasm such as multiple myeloma. There is eosinophilic intracytoplasmic protein inclusion in the liver that's seen in the alcoholic liver disease. This protein inclusion, it is called Mallory bodies. It's hyaline alcoholic bodies composed predominantly of aggregates of intermediate filament that resist degradation. In this picture, showing the protein reabsorption droplet in the renal tubular epithelium in patient with a nephrotic syndrome, because normally the glomeruli should not passing or allow the protein passing through it. But when there is any disease affecting the glomeruli, such as in the nephrotic syndrome, as we said, minimal changes, glomerulonephritis, membranous or focal segmental glomerulosclerosis, all of these might lead to the nephrotic syndrome, which is a group of disease that affect the kidney and cause passing of the protein through the glomeruli into the renal tubule, which appear here as a hyaline pink granule in the renal tubular cells. This is a Russell body. This is a Russell body, red colored. Look at it, red colored dot consisting of mainly of immunoglobulin, where in the rough endoplasmic reticulum of the plasma cell. This is a plasma cell. This is in patient with multiple myeloma, and look at the plasma cell. Plasma cell appear the cells is larger than lymphocyte with eccentric nucleus. The nucleus is slightly pushing into the side of the cell, which is a characteristic feature of the plasma cell. Plasma cell synthesis immunoglobulin. So in cases when there is abnormal proliferation of the plasma cell, such as in the neoplastic proliferation of plasma cell, the accumulation of this immunoglobulin, which is synthesized in the endoplasmic reticulum in this cell, it is called Russell body, appear as red colored dots. This is a Mallory hyaline body, Mallory body, which is intermediate filaments consisting of intermediate filament. It is seen in alcoholic hepatitis or in the alcoholic liver disease. This characteristic feature of the one of the characteristic feature of the alcoholic liver disease, accumulation of the intermediate filaments in the liver cell. Now we are coming to the glycogen, another substance that might be accumulated in the cell when there is extracellular, when there is excessive intracellular deposit of glycogen. It's usually associated with abnormality in the metabolism, either of glucose or glycogen. In which clinical setting we can see the glycogen accumulated? In poorly controlled diabetes mellitus patient and the sukkari. So the glycogen accumulate in renal tubular epithelium, or sometimes in the cardiac myocyte, in the beta cell of the islets of Langerhans. تعرفون من يصير عندنا diabetes mellitus there is abnormal metabolism of the glucose, sometimes due to the deficiency of the insulin, which are usually produced by the beta cell of the islet cell of the Langerhans, or sometimes there is a decrease or increase in the peripheral resistance. That to say, the patient has insulin, but there is peripheral resistance to the insulin, especially those patients which is obese, have overweight, sometimes polycystic ovary. All of these اللي عندهم peripheral resistance to insulin. There is also a group of genetic disorders like glycogen storage disease, glycogenosis, glycogen accumulated within the cell because there is deficiency in the certain enzymes that are responsible of the some steps are included in the steps of the metabolism of these substances. As we say that in these diseases, enzymatic defect or in the synthesis or breakdown of the glycogen, resulting in accumulation of the glycogen with secondary, of course, injury to the cell and then cell death. This is a histopathological examination or microscopical examination of the normal liver. Here, central vein, and here is the portal trade at the periphery of the lobule. This is a lobule. In the portal, we can see the bile duct, and vein, and arteriole. This is a normal liver. There is no fibrosis. The cell of the hepatocyte seen as a cord تشبه. شوفوها عبارة عن كأنه مساطر أو كأنه عبالة cord of the hepatocyte radiating from the from the central vein toward the portal tract كأنه مساطر ممتدة من central vein إلى البورتال tract. هذه zone 1 هاي zone 2 and this is called zone 3. This is a microscopical feature of the patient with the liver biopsy from the case with the glycogen storage disease. Look at the clear cell. Here there's the hepatocyte showing clear cell because of the accumulation of the glycogen. It's abnormal, and at the same time, look at here, if we compare this microscopical picture with the previous one, we can see this is a bands of the fibers or the collagen fibers that extend between the lobules. So this patient, in addition to the clear cell or the accumulation of the glycogen, which appear the cell as clear because of the accumulation of the glycogen, this induce the fibrosis of the liver. This is liver tissue glycogen, also a droplet in the left side. Look at it by PAS stain. This stain is by PAS. White vacuole in the right side by H&E. Hematoxylin and eosin stain used to stain this tissue, and this is a PAS, periodic acid shift. You have to know very well, yeah, you have to understand or to know the stain that are used in staining the tissue in histopathology. Now we are coming to the pigments. They are color substance which might be endogenous or exogenous. The endogenous is synthesized within the body, while the exogenous is coming from the outside the body. The most common exogenous pigment is carbon. Carbon usually coming from the coal dust من مناجم الفحم أو من الفحم يعني بالضبط الرماد أو غبار الفحم. air pollutant من تلوث الجو. when inhaled طبعا هذا تكون عادة دول الناس اللي يشتغلون بمناجم الفحم الكول ماينر عادة يستنشقون هذا الكربون, and هذه الكربون particle phagocytose by alveolar macrophages and then accumulate in the transported طبعا through the lymphatic channel to the regional lymph node. ممكن نشوفها أو ممكن نشوفها pulmonary parenchyma, يعني باللنج نسموها anthracosis. زين. Heavy accumulation may induce a fibroblastic reaction that can result in serious lung disease called pneumoconiosis. While endogenous pigment, which is basically those pigments including lipofuscin, melanin, and derivatives of hemoglobin. Lipofuscin, which is called wear and tear pigment, basically this accumulation of these substances might be due to the aging, which appear as insoluble brown, yellow granular intracellular material that accumulate in the variety of the tissue, heart, liver, brain. Consequently, it leads to the brown color of the tissue, brown atrophy of the heart. This is basically related to the age. The other substance, which is the brown-black pigment, is melanin, which is synthesized exclusively by the melanocytes. It is usually found in the epidermis of the skin and act as an endogenous screen against ultraviolet radiation. Hemosiderin, this is another pigment, which is hemoglobin-derived pigment. You can see or you can understand this pigment when we have a trauma in the arm, or when you hit by something in the arm. you can see that the bruise at the site of the trauma within few days, it's for the first 2 days, it's appear as bluish in color, while then the color is changed into the yellow. So this is because of the hemosiderin accumulation in the skin or in the tissue, because it is which resulted from the hemorrhage in the skin and subcutaneous tissue. So the iron of the hemoglobin are accumulated as golden yellow hemosiderin. هو الحديد الموجود بالهيموغلوبين اللي يترسب أو يتجمع in the form of hemosiderin. This is a brown atrophy of the heart. The heart is small atrophic. Basically is a brown color due to the accumulation of the lipofuscin pigment within the myocardial muscle. Here, lipofuscin particles or granules in the cardiac myocytes, in the light microscope, and in the electron microscope. Look at it. This is a lipofuscin granules. This is a malignant melanoma. It's a malignant proliferation of the melanocyte in the skin, most commonly seen in the Europe, in the Scandinavian, and in the North Europe and USA, North America, because of the direct exposure to the UV light, and because of their faint skin, because they have very white complexion. This is also another picture showing malignant melanoma, which is a malignant tumor of melanocyte, deeply pigmented skin, deeply pigmented elevated mass on the skin. Look at it, very high, darkly. Hemosiderosis. This is a condition which is characterized by systemic overload of the iron. The hemosiderin deposited first in the phagocyte, mononuclear phagocyte, in the liver, in the bone marrow, in the spleen, and lymph node. But then, later on, the parenchymal cell of the body, especially the liver and heart and the pancreas, might be affected. Hemosiderosis basically occurs in the setting of, first, increasing the absorption of dietary iron. It's called hereditary hemochromatosis, one of the most common inborn error of metabolism, which is autosomal recessive, in which excessive absorption of the iron from the intestine, which leads to the extensive accumulation of the iron in tissue. It is a really serious situation. The patient with hereditary hemochromatosis should be diagnosed early in order to avoid development of the liver cirrhosis, heart failure, and diabetes mellitus because of the accumulation of the iron in the tissue, and cause damage, of course, of this of the tissue and organs. Or in hemolytic anemia, because of a frequent blood transfusion in certain type of the hemolytic anemia, so also it will lead to the hemosiderosis. Localized hemosiderosis seen in the trauma, which is seen in the hand, feet, trunk, or as dark blue patch, because it is due to the local hemorrhage in the skin and subcutaneous tissue, and the color gradually change from the brown, blue, yellow, and then disappear within 1 week. This is a hemosiderosis. The stain that are used to stain the iron is a Prussian blue pearls stain, which showing deep blue color. This is a section in the spleen. This is a Prussian blue, which appear the iron appear in this stain blue granules in the parenchymal cell of the liver. Here in the stain H and E, hematoxylin and eosin appear as a golden brown granules in the parenchymal cell of the liver. When stain this tissue by Pearl's stain, Prussian blue, it appear bluish in color. Very nice, beautiful picture. Now we are coming to the calcification at التكلسات, pathological calcification in which there is abnormal deposition of the calcium in the tissue. Might be dystrophic calcification or metastatic calcification. Dystrophic calcification, in this form, calcium salt are deposited in the necrotic tissue with normal calcium level in the blood. Dystrophic calcification, you have to know very well that basically the calcium deposit in the necrotic tissue, in the disease damaged tissue, while the calcium in the blood is normal. It is seen in TB, caseous necrosis, calcification of the atheroma in advanced atherosclerosis, calcific aortic valve in the elderly, and carcinoma of the breast. In the carcinoma of the breast, when we see calcification in the mammography, this is very, it's one of the important sign to go further investigation to the breast of the female. This is because this calcification might be beyond more aggressive process in the breast. Maybe there is necrosis, maybe there is malignant tumor, because it is seen in the carcinoma of the breast. It is seen, the calcium salts basically seen in the fine white granules or clumping, appear gritty, felt gritty, deposit or stony hard white nodules. When you cut the section grossly by cut up, it will see that it will feel that the gritty deposit or stony hard. While in metastatic calcification, which is characterized by deposition of the calcium in normal tissue, but it is due to the increased level of the calcium in the blood. So we are coming here to the causes beyond this deposition to increase the calcium in of the blood. What are the main causes of the hypercalcemia? Increased secretion of the parathyroid hormone, hyperparathyroidism, such as in cases with a parathyroid adenoma or parathyroid hyperplasia, which lead to the increased parathyroid hormone, because parathyroid hormone, it causes immobilization of the calcium from the bone into the blood. يزيد الباراثايرويد هرمون يطلع الكالسيوم من البون، يزيده من البون يوديه للبلد. لهذا عندنا increase the level of the calcium in the body in patient with increased parathyroid hormone. Or sometimes due to the destruction of the bone, such as in immobilization, or might be due to the bone involvement by the certain tumors, multiple myeloma, leukemia, and vitamin D related disorders, or in the renal failure, in which phosphate retention lead to the secondary hyperparathyroidism. And it is also because renal failure, it causes phosphate retention. Phosphate retention lead to the secondary hyperparathyroidism. Secondary hyperparathyroidism, why it is secondary hyperparathyroidism? It is due to the why? Because it's not caused by the primary disease of the parathyroid. Primary hyperparathyroidism, it is due to the hyperplasia of the parathyroid, or due to the parathyroid adenoma, or might be carcinoma. Secondary, that's mean there is increase in the secretion of the parathyroid from the parathyroid hormone from the parathyroid gland, but the cause is not in the parathyroid itself. It is due to the other cause, might be due to the renal failure. So you have to differentiate in between two terms. Metastatic calcification resembles dystrophic calcification. It can occur widely throughout the body, but usually it's affect the interstitial tissue of the blood vessel, of the kidney, of the lung, and of the gastric mucosa. Actually, any part of the body or tissue can be affected by this. This is a microscopical view. This is a calcium in patient dystrophic calcification in the necrosis, in patient in the granuloma, which appear purple ink. This is in patient with aortic valve, also dystrophic calcification, which appear, it's basically seen as irregular white masses of dystrophic calcification. This is also in the kidney in patient with metastatic calcification. It is due to it is called nephrocalcinosis, dark purple color, which is seen in the renal. Now we are coming to another topic in this lecture, which is the aging. الكبر. واحد يكبر عمره. There are certain points and important points that I would like you to know about it in order to end up with the cell injury. Aging is one of the strongest independent factors for many chronic diseases like cancer, Alzheimer, ischemic heart disease, and etc. Aging of any individual is due to the cellular aging. ليش واحد يكبر؟ لأن الخلايا مالته تكبر. The aging usually regulated by limited number of gene and signal pathway that are evolutionarily conserved from yeast to mammals. يعني من الخميرة إلى الماملز الثدييات. Cellular aging, it is a result of a progressive decline in the lifespan and functional capacity of the cell. هي الخلية تفقد قدرتها على الحياة، تقل decline progressive، يصير progressive decline يعني بشكل يعني يقل، يعني شلون واحد يقل عمره وتقل القابلية capacity of the cell to do its normal function or to perform its normal function within the time. Several mechanisms are responsible for cellular aging and include DNA damage. There is a variety of metabolic insults and stress that accumulated over time and cause damage to the DNA in the nucleus and in the mitochondria. Some of those DNA damage is repaired by DNA repair enzymes, but some of them persist and accumulate as cell age. Some of these aging syndrome associated with defects in DNA repair mechanism. And the lifespan of the cells which are taken from experimental animal can be increased if their response to DNA damage are enhanced or protein that stabilize DNA are introduced. Decrease in the cellular replication. We know that all normal cells have limited capacity for replication because after fixed number of the divisions, those cells become arrested in a state called non-dividing state or replicative senescence. تتوقف يعني القابلية الخلايا الطبيعية هي مو قابلية مطلقة. إذا الخلايا لها قابلية infinity مطلقة، هذا لا يمكن أن تكون. هاي ممكن لأن أكو إلها حدود، إلها capacity for replication. Because after number بعد عدد من الانقسامات لازم تتوقف. يسموها هذه القابلية replicative senescence. بالaging بالعمر من يكبر واحد it is associated with the progressive replicative senescences بشكل مستمر. هذه الخلايا توصل إلى مرحلة non-dividing cell stage يسموها progressive replicative senescence. Cell from patient with Werner syndrome. What is Werner syndrome? It is a rare disease. طبعا this is an inherited genetic disease. It's characterized by premature aging. شخص يعجز من وقت بسبب جيني. when compared من إذا أخذنا بالcellular life span مال سوينا لها tissue culture وقارناها مع الخلايا اللي أخذت من healthy children اللي have capacity to undergo more round of replication and longer lifespan. شفنا إنه الخلايا مالت هذا الفيرنر سيندروم ليش يصير عنده premature aging؟ إنه خلايا عندها replicative senescence فيصير عنده premature aging مقارنة بالأطفال الأصحاء. نفس الشيء نشوفه بالبروجيريا سيندروم. هذا شكل الطفل اللي بروجيريا سيندروم اللي هو عنده premature aging. شكله كأنه شخص عجوز كبير السن مع العلم هو عمره صغير، بس بسبب إنه life span of the cells because of the replicative senescence of this more عندهم progressive replicative senescence than the cells of the normal healthy child. In human cells, the mechanism of replicative senescence involved progressive shortening of telomeres, which result in cell cycle arrest. What are the telomeres? The telomeres, short repeated sequence of DNA present at the end of the linear chromosome. They are very important. ليش important? It is ensure the complete replication of a chromosome and protecting the end from fusion, from fragmentation, degradation. Telomeres consisting of hundreds or thousands of repeats of the same short of DNA sequence, which vary between the organism. لكن repeats هذا gradually make up telomeres eating away slowly over time with each division. لأن somatic cell when replicate a small fraction of the telomere is not duplicated. هاي تنقسم لكن هذا يبقى ما is not duplicated ما يتضاعف مع الخلية يبقى. فمن شنو يصير؟ يصغر حجمه يصغر progressively decreased or becomes shorter. As consequence for its shortening, the DNA may break and end cannot be protected. Some cells have the ability to reverse telomere shortening by expressing telomerase. So what is telomerase? Telomerase is RNA-dependent DNA polymerase. It is the enzyme that can make DNA using RNA as a template. So the telomere length is maintained by nucleotide addition that mediated by the telomerase. Telomerase activity, where it's found? It's found in the germ cell because they are a productive cell and it's reproducing and proliferating cells, but less in stem cells, and it's absent in most of somatic cells. In cancer cells, telomerase is often reactivated. The other factors that involving or including in the aging is defective in protein homeostasis. Because over time, the cell cannot maintain normal protein homeostasis. Increased turnover, decreased synthesis. يزيد الاستهلاك للبروتين بالخلية ويقل السنتسز، يعني يزيد الهدم ويقل البناء. يزيد بالكبر، يزيد الهدم. بالبداية أول شيء بالبداية العمر لما يكونون أطفال صغار كل بناء خلايا كلها خلايا جديدة إلى أن يوصل عمر معين. في منتصف العمر يبدي شنو يصير؟ اكو توازن يصير، يعني البناء والهدم يتوازن. بعدين يبدي كله الهدم turn over, some increase in the turnover ويقل السنتسس، يقل البناء. Abnormal protein homeostasis that happened or that occurs by time affect the cell survival, function, replication, and sometimes there's accumulated as misfolded protein. It would trigger apoptosis. So by aging, the aging is the death of the cell take place by apoptosis. Increase the death of the cells. تقل. هذا واحدة من الميكانيزمز إنه يصير شرينكج بالخلايا. ليش الشخص يصير به ألزهايمر، الشخص يصير عنده يتعرض إلى أمراض كثيرة منها chronic diseases، مثلا الدمنشيا، البرين يصير به أتروفي، يقل size of the brain مقارنة ويا النورمال brain of the healthy young individual. يعني هاي جزء من الأسباب اللي تكون موجودة أو اللي ممكن أن تفسر إن الaging. There are other factors that may contribute, maybe progressive accumulation of metabolic damage, possible role of the growth factor that promote aging in simple model organism. This was the last lecture actually of the cell injury. I hope that you understand the cell injury in general, digest the material very well, and I hope that this, because the cell injury is one of the important chapter in the it's important chapter in the pathology. According to the chapter, if the concept of the cell injury, you will understand the other topics and that would be followed. In next week, we will start with the inflammation, healing, repair. It's more broadened subject actually, or topic, but it's based of course on the cell injury. So you have to study well the lectures, understand the concept in it, memorize some of the facts that are present in the slides. Not only understand them, you have to memorize them, and then in order to continue the next chapter, inflammation, next week. Thank you very much.